Do you need surgery for your rotator cuff problems? Welcome to Talking with Docs. I'm Dr. Brad Wiener.
I'm Dr. Paul Zalzo.
And I'm Dr. John Haverstock.
Thanks for joining us. Thanks for taking a break from watching the fails video that you've been watching or the cute animal video, and you're watching something about your health. So you're doing something right. We're going to talk about surgery for rotator cuff problems, and we have a shoulder surgeon, Dr. Haverstock, who's been kind enough to hang out with us this early morning.
And most importantly, we have another video that talks about the non-operative side, which is the vast majority of treatment for rotator cuff problems. So somewhere in the range of, would you say 5 or 10% end up getting surgery?
Yes.
Pretty low.
Right. Yeah.
So don't give up on non-operative treatment before you watch this video. Okay, so let's start at the beginning.
Right.
What's the goal of an operation? Why do we start talking about surgery for rotator cuff problems?
So when you talk about a rotator cuff tear, the tendon has pulled away from the bone.
Okay.
So the goal of surgery is to bring that tendon back to the bone and have it heal.
Okay. And are all of the tears, are they all pulled off the bone, or could you have a tear kind of that's not at the insertion, like a rip in your jeans kind of thing?
You can have that in substance tear, like a rip in your jeans, but the vast majority we treat by bringing them back to the bone, because that's the way our techniques work. You know, sometimes we can just stitch up the tendon, but that's less common.
And what are the indications for surgery? So when do you bite the bullet and decide, yeah, we're going to operate on this? Is it because it's traumatic versus a degenerative one, or is it because we failed non-operative management? What's your kind of algorithm?
Right. So if you've had a tear as a result of a fall or a discrete injury that's big and that limits your motion despite a few months of physio, we want to fix that because it's not your normal state. That's more common, okay? But the more common tear to begin with is the degenerative, the age-related tear, and those are the minority of what we're fixing because they usually get better with physiotherapy.
Okay, or physical therapy if you're south of the border.
Yeah. Okay, so you've failed non-operative treatment. What about age? Is age an indication or a contraindication for surgery? Who does well with these?
Yeah, I think age is something that every patient and doctor have to assess between themselves.
Okay.
So age is not a limiting factor. Of course, it's less common perhaps to operate on people in their 80s and 90s with this, but age is not a...
The deal is, when we're talking about surgery and we're talking about age, the reason that it's important is because we're always looking at a risk-benefit ratio. We try and achieve benefit with surgery, but if the risks get too high, then the risk-benefit ratio tips in the favor of not operating or operating. As we chronologically increase our age, our risks associated with surgery, that means risk of something bad happening like a heart attack, stroke, or even death, those go up a little bit. So that's why we always take that into account when we're trying to make a decision as to whether or not to operate on someone.
And I think too, as we get older, sometimes the tissues become not fixable, and I think it's hard for us to accept the fact that we have a problem maybe that you can't fix, but at some point you're tending us to the point where you can't fix it, and then we'll talk about other options. So when we are talking about surgery, what does it look like? So do you go to sleep? Are you sedated? How does it work?
Yes, so you often would have a general anesthetic. You go to sleep. Sometimes before surgery, the anesthetist can put some freezing around your neck that makes your arm and shoulder numb for the day. So you need less anesthetic, and you wake up and you might not have any pain at first. So after you go to sleep, we clean your shoulder very carefully in an operating room. And we usually can do it either arthroscopically, keyhole surgery with small incisions, maybe 4 to 6 centimeter incisions around the shoulder, or you can have a moderate-sized open incision where you just retract the tissues and have a bigger exposure.
Okay.
What's your preference?
Arthroscopic, yeah. You get a better view, smaller incisions. You can treat other problems at the same time.
Would you say that the literature says for outcomes that they're comparable though?
They are certainly comparable, yes. If you address the problem in a good way and have good therapy, you're going to have good success.
Okay.
All right, so you've got the arthroscopic version or the open version. Either way, both results are pretty good. You're going to have surgery. Are there any risks associated with surgical intervention for rotator cuff pathology?
Important question.
Yeah, so if we want to say specific to the rotator cuff, sometimes there's a chance that, like you're saying, is sometimes we can't pull the tendon back. Sometimes the tissue's too thin and we grasp it and it won't hold the sutures. There's a chance that it might not heal when the conditions aren't favorable. And of course, we're going to expect that you're going to have pain. Sometimes it's a lot of discomfort if you're not taking the right steps or using the right tools afterwards. Your shoulder can get stiff, and occasionally that stiffness gets significant.
Okay, and then of course you have the sort of risks associated with any surgical procedure: heart attack, stroke, death, blood clot, infection, pneumonia. Bad things can happen, but we do take precautions to really minimize the chance of something like that happening.
Yeah, for sure. So now you've had surgery. What's our plan? So I'm gonna try to plan with my family or my friends or whoever's gonna be helping me. Do I go home the same day? Do I stay overnight? What's it look like? What's the recovery look like for me?
Yeah, that's a great question because the recovery is long. So
Sorry.
you're going to spend probably 6 weeks in a sling. I tell people you can take it off for bathing and physiotherapy. You go home the same day. And it can be difficult, just like when your shoulder's sore beforehand, it can be difficult to do simple things like getting dressed, bathing, working. All of these things are a challenge.
What is the purpose of the sling? So I'd be like, do I really need this sling?
Yeah. The sling is to protect the repair.
Okay.
So whenever you're moving or readjusting your position in bed, for example, that's stressing the repair. And since the repair takes 3 months to heal, much of its strength, not all of its strength, the sling is designed to protect it for that duration and also increase the awareness of the people around you that you need some protection.
And we have that battle in just about every musculoskeletal part. We've got to give time for the part to heal, and then we're going to make it super stiff because we've immobilized it. Then we're going to get the physical therapy and the physiotherapy going to get it moving again. Same thing with the shoulder. We're going to make you stiff because we've got to let the stuff heal, and then we've got to get you moving again after with some kind of exercises, which hurts.
So when it comes to therapy, I think there's two different schools of thought. There's the early versus the delayed mobilizers, and whether it's active or passive. Can you talk a little bit about what you think is right? And obviously every patient and every surgery is a little bit different.
Yeah. I think that being in a sling and seeing a physiotherapist, physical therapist, is the most important combination because they can help you navigate. Are you getting stiff? Are you doing protected motion? So doing protected motion, sometimes we talk about active assisted, like your muscle is doing it and you're helping it, and so you know what's feeling right for you. So some early active assisted motion is definitely part of it.
How early? Like day 2,
Days.
Okay, so
Yeah.
so just so people
Within
know.
days. Yeah, absolutely. So it's about protecting it in a mindful way. So seeing your physical therapist before surgery can help make a plan. Your surgeon will have a protocol that will talk about what they think is best, and then they'll maybe make adjustments based on how the surgery went.
Okay.
Part of that surgery, is there also a decompression component to that surgery? In addition to just repairing that tendon, there's
Yes.
also been some bony work.
That's right.
Often.
Yeah. So there's two kind of main add-ons. One, sometimes the roof of the shoulder, we call it the acromion. Sometimes it's got a hook shape, and so it can be pressing down on the rotator cuff. And if that's the case, usually we're going to trim that bony hook off so it's not pressing and irritating the tendon.
Okay.
And the other major add-on is addressing the long head of the biceps tendon, which passes right through the shoulder joint. It's very often torn, so you've got to have a plan for that because that can be a component of your pain.
So that's why it hurts more than just stitching the tendon back together. There's sometimes some bony work or some other tendon work as well.
Okay, you said it takes a long time to recover. What are we talking about for getting back to work and getting back to sports or recreational activities?
I think that if you can do your job in a sling and you can get to your job, then maybe you could be doing it within 2 to 6 weeks perhaps.
Okay.
If you depend on moving and lifting and you're more active at your job in terms of physical labor, it's going to be quite a bit longer.
Like 3 to 6 months potentially.
Yeah, 3 to 6 months. I think the worst plan or the longest delay in return to work is if you'd have to do heavy or overhead things. I think it could be up to 6 months in that circumstance, depending on your tear.
Keep in mind, you probably couldn't do that type of job before you had the surgery anyways because you're in such rough shape with your shoulder.
That's true.
Okay, we always like to talk about success rate. So is this an operation that even works? Patients are like, they're just trying to sell you surgery.
Yeah, it definitely works. When you look at the numbers, if you get into the science and the research, you're going to see success rates that go from 20% to 90%. And that's because some tears are 6 centimeters and some are 6 millimeters.
Right.
And some have been there for 6 weeks and some of them been there for 6 years. So it's a mixed bag. I think if you're getting timely attention, and you're having an MRI before surgery, and your surgeon does these regularly, I think the success rate is quite high.
Okay, good.
Okay, and is it the kind of thing where it's like, okay, I had it on one shoulder, guaranteed I'm going to get in the other shoulder, or is it just not guaranteed that it's going to happen to the other shoulder?
It's not guaranteed at all. I mean, certainly there's a likelihood. I wouldn't say it's high. I would say maybe 20 to 30% might have a similar problem.
Pretty high.
Yeah.
Okay.
One more scenario I want to discuss. So you have a massive tear,
Yeah.
been there a long time. You've been told, hey, sorry, we cannot fix this tear. I'd say 20 years ago, that person was kind of stuck. They got
Yes.
like a half shoulder replacement, maybe it didn't work very well, but now there's potentially an option that can solve this problem. Can you talk to that a little bit?
We've got a few options depending on your age and circumstances,
Yep.
but sometimes bringing in some additional tissue, if the rest of the tissue is okay and you desire a high activity level, you're young and healthy, it's got a mixed...
Like your own tissue, like part of your lat or something like that?
Yeah, bringing in a different tendon or sometimes tissue from a donor. It's not a home run by any chance, but it might be the right circumstance for a few patients.
Okay.
And then as we get older, things like a joint replacement become even more favorable because we know it's going to last the rest of your life. And the healing time actually from a shoulder replacement or the recovery is both more predictable and perhaps even a bit shorter than repairing the tendon, which is a bit surprising to most.
And what gets you, one of the things that gets you to jump to that is the shoulder itself, the joint itself is now damaged because of this chronic rotator cuff insufficiency.
Yes.
You've got actual damage in the joint now. Because if you've got a really damaged joint, repairing the tendon is not going to help you significantly. At that point, we've got to start looking at a replacement of the whole shoulder.
And is it just a regular shoulder replacement if you have a totally deficient rotator cuff?
So we call it a reverse shoulder replacement, and we've got another video.
You kindly did a video with us on that exact topic. We'll
check
put a
that
link.
out. Link.
Now you know. So tons of different options for surgical treatment of rotator cuff problems. But I'd say the take-home message is first, stick with the non-op. This is a very high chance of getting you through this difficulty and getting you back to function. But if you don't, you have now can talk to your family doctor or potentially get referred on to a specialist to talk to the details of potential surgical options.
Yeah,
for you.
if you swiped onto this video first, please swipe back, go back and watch the one where we talk about non-operative treatment because that's by far the most common way to treat rotator cuff pathology. This is just in those cases where that's just not working.
Okay, now you know. And if you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health. Thanks, Dr. Haberstock, again.
Thanks for having me.
Thanks for joining us, John. We'll see you next time.